So we have three different options now for colorectal cancer screening. One is colonoscopy. And the reason why that's been the main screening test that we've used in the United States is because it's the most accurate screening test that we have. And when I say accurate, what I mean is what is its sensitivity and specificity for colorectal cancer and then also for advanced polyps, which is the other neoplastic lesion in the colon that's really important to detect because there's a high percentage of those, around 25 to 30%, which will go on to become colorectal cancer if not removed. The sensitivity and specificity of colonoscopy is over 90% for the advanced polyps and for colorectal cancer. The other option, which is a non-invasive option that we have been recommending, is the stool-based test. And there are two options there. One is the FIT test, and the other one is the Cologuard test. Those tests are very sensitive for detecting colorectal cancer. The Cologuard test is over 90%, and there's a newer version that's going to be offered soon, and that's around 95% sensitive for detecting colorectal cancer. So pretty close to colonoscopy. The FIT-based test, not quite as good. It's more like, depending on the study you look at, between 70 and 85% sensitive for colorectal cancer. Neither one of those tests is as sensitive for detecting those advanced polyps. They're more around 45% on average. The FIT test being lower than the colonoscopy, or than colonoscopy. Now we have a third option that we'll be talking about, which is a blood-based test, which is as sensitive as FIT-based testing for detecting colorectal cancer, but not as sensitive for detecting those advanced polyps. Yeah, so currently what we recommend for screening is that people between the age of 45 and 75 undergo colon cancer screening. And we have different recommendations depending on what the risk is. If we look at people who are average risk and we look at the compliance with being screened, and that's either doing the FIT-based test, the Cologuard test, colonoscopy predominantly. There are some other screening tests that can be done, but aren't typically done in the United States. What we find is that if we use the parameter of as someone who's supposed to be doing screening, so again, between 45 and 75, have they done it at least once? The rate is around 70, 75% compliant. So about 30% of people are not compliant. If we instead look at screening as being a program, which is the way I tend to think of it, and not just a one and done, but a test that gets done at intervals during that time when somebody should be getting screening, then the compliance rates start dropping. And now we start seeing the compliance is probably in the low 60%. So roughly about 30 to 40% of people are not compliant with getting screened for colorectal cancer when we restrict it to what has been traditionally available for screening tests. That's a really great question. So what are the barriers for colorectal cancer screening and why don't we have 100% compliance? There are a number of different barriers. One of them is patient motivation, and you have to have a higher level of motivation to do colonoscopy-based screening than to do FIT-based screening. And it's because colonoscopy requires that preparation, which is probably the biggest barrier that people don't like. But the other barrier is that it's logistically more difficult to do. You have to take time off work if you're working, or just time off just your schedule for whatever you're doing. And then you also have to find someone who can get you to the colonoscopy appointment. Typically people have to drive there. Even if you walk, because you've gotten sedation after the colonoscopy-based procedure, you have to have someone who can assist you in getting home. And so those are barriers that stop some people from being able to get colonoscopy. So that's where the stool-based tests are an option for people who look at those barriers and they say, that's too much for me, I can't do colonoscopy-based screening. The stool-based tests get over those issues because there's no preparation involved. However, they do have the issue of having to handle stool, which a lot of people find really distasteful, particularly because if they do the stool-based testing, it's not just once. You have to do that every 1 to 2 years. And so it's that issue of having to do it time and time and time and time and time and time and time again. Because if you are compliant over that 45 to 75 period of time, that's 30 years, that means you're going to be doing 10 of those, or not 10, you're actually going to be doing 15 of those stool-based tests. And it's interesting when we look at studies of compliance with multiple rounds of the stool-based testing, what we find is unexpectedly that the highest compliance is that during that first round. And that's where we see, let's say it's roughly 70% compliance, maybe up to 80%. And then the second round, it goes down. Third round, it goes down. So typically by the time you get down to like those fourth and fifth rounds, now you're actually around 30% compliance. And yeah, that doesn't work for a screening program. So that's been the issue with the stool-based tests. And that's where now we have this newer option that is likely to be available with the blood-based test that gets around some of these barriers that have been in place for the stool testing and the colonoscopy-based testing. Yeah, so this gets into a really important aspect of cancer screening. And so one of the big things that we've recognized over the last 10 or 15 years for cancer screening in general, but there's been a lot of work done for colorectal cancer screening, is that the major factor that affects compliance is patient choice. And so what we know is that if you give people just one option, that's when you see the lowest compliance rates. Makes sense. People have different priorities. There are different things that affect their decisions about what they want to do with their healthcare. So if you have different options that have different features that would affect whether someone might choose option A versus option B, that's going to result in the highest compliance. And so where the blood test comes in is that now we have a test that's convenient. It can be added on to blood tests that are getting done as part of kind of regular healthcare. So you don't have the aspect of having to handle a stool sample. You don't have to have the aspect of with the stool sample finding time. Because typically what happens is that you have to do this at home, so then you have to figure out, okay, how am I going to do that, and where am I going to find the time, and I'm going to remember to do it. Then once I do it, then I have to figure out how do I get the test back to where it needs to go in order for the test to be actually assessed in the laboratory. So you get around all those type of issues, and then you get around all those issues that we've talked about, which are the barriers for colonoscopy-based screening. And so there, what has to happen, and what we're all advocating for in the colon cancer screening community, is that there's a shared decision-making process. So what we recommend is that people who are 45 or at the time when they're due for their next screening test, is that they have a discussion with their care provider, and the care provider lays out, these are the options, these are the advantages and disadvantages. Because it's important to recognize that the blood-based test has an accuracy that's similar to the FIT-based test for colorectal cancer, but it's not as accurate for detecting the advanced polyps. It's about maybe a quarter as accurate as the FIT-based test, and it's about what's 13% sensitive for detecting advanced polyps, and colonoscopy is about 95% sensitive for detecting the advanced polyps. Yeah, great question. I think this is where the blood-based test, the thing that's exciting about it is that if we go back to thinking about compliance, and we look at 30 to 40% of people are not being compliant with colorectal cancer screening. So that's where the tragedy is. We have a test already, colonoscopy, that's very accurate, detecting colorectal cancer and detecting advanced polyps. But if it's not used, it doesn't work at all. And so we've got 30% of people who are opting not to do colonoscopy, not to do the stool-based testing. And what we're hoping is that those people will now do colon cancer screening with a blood test that's available, because for whatever the reason, whatever the barrier was, that barrier is going to be taken down by having a blood test option. So that's the big hope. There is some concern that if people wholesale opt to do blood-based testing as opposed to doing colonoscopy-based testing, that based on modeling studies will actually result in higher rates of colorectal cancer, because what would happen is that those advanced polyps that we're detecting by colonoscopy are not going to be detected by the blood-based test. So there is some concern that that could happen. I personally think that's unlikely. My expectation is that the people who are choosing to get colonoscopy-based screening value the accuracy that that test offers and will continue to do that. And they value that over the convenience of doing a stool-based test or now a blood-based test. And for those people who don't value that accuracy and instead value the convenience, that's where the blood test will really be a good choice for them. So the next big step that has to happen and that's anticipated, when it's going to happen, we don't quite know, but my expectation is probably sometime over the next 4 to 8 months, is that CMS will authorize reimbursement for the blood-based test. Because the lived experience is that you can get a Shield blood test right now. You can order it, but it's a limited diagnostic test, so which means that there'll be a high out-of-pocket expense. The test retails for about $895. And so now the FDA has approved it. CMS has said that in a prior statement, that a blood test that meets the performance that the Shield test meets, that they would recommend that be reimbursed. So there's no reason to think that they won't make that decision. And as we know, private insurers typically follow suit. And so from a lived experience, my expectation is that this will be an option that people can have their physicians order, that will have a low out-of-pocket expense, and that will happen sometime by, let's say, early to mid 2025 for most people.